I thought about this title late last night and I realized it's wrong. It really is, why are we here? Why are 250 valued clinicians spending their entire day talking about this subject? And the reason is it matters. Because we work in one of the largest healthcare delivery systems in the country, taking care of people who traditionally are underserved. And if you take a look at how we've done with diabetes in the past, some of it's been stellar, some of it not so much. But the really exciting thing, and I've been with the department for more than 30 years now, there's been more change and more progress in organized care delivery for chronic care in the past 2 years than in my previous 28. And that's what's so exciting, and that's what gets my juices really flowing about what we're talking about today. So just a couple of factoids about the county, because it always strikes me that people from Harbor know a lot about Harbor, and people from MLK know a lot about MLK. But people tend, I've been lucky my whole career that I've gotten to travel around the county, but it's amazing how when we have some of our meetings of the work groups, it's the first time that people have met each other, and they've been DHS employees for 20 years. So it's really exciting to see us really starting to behave as one DHS. We live in the largest county in the United States. It's over 4,000 square miles with 10 million people. It's the only one that I know of that has islands as well as the mainland. It's incredibly diverse and has a large subsegment of the poor population. Now, one of my favorite statistics used to be the uninsured of LA County would be the second largest county in the country by themselves. Guess what? That's no longer true, and that's something to be celebrated. Now, our department is equally huge. We're the second largest safety net delivery system in the United States, second only to New York City Health and Hospitals Corporation. Our budget broke $4 billion this year. There are 250 of you in the room. There's 21,000 who are still at work. We have 3 major hospitals, 2 major medical school affiliations, and between LAC, USC, and Harbor alone, we do almost half the trauma in the entire county. We have one hospital that year after year after year is on the US News and Best 10 hospitals in the United States of America, and something to really be proud of. What's grown, though, is our outpatient network. We've really begun to organize how we care for patients in outpatient. And you notice I didn't say ACN, I said outpatient, because we need to think of ourselves not as hospitals in the ACN. I want to get rid of that chasm. I want to think of ourselves as we do inpatient care when we failed in the outpatient environment. And that's how we should think about every patient who's admitted with an ambulatory sensitive condition. That's a failure of our outpatient environment. And hopefully the mic won't keep on coming in and out. Well, why else it's important is because of why we all chose to work in the safety net. And which study you look at, if you're poor, uneducated, female, and a person of color, your care's just not as good as if you're a white middle-aged male like me. And it's been studied over and over and over again. Now, our patients, equal to the size of our department, number about 800,000. A couple of 100,000 of those are seen in the community partner sites. Last year, half were uninsured. Now it's less than a third. So we have an incredible increase in the covered patient population. And guys, it's no surprise that we are in a better financial place this year than we have been in the 30 years of my career, partially because of Mitch Katz's great management, but also because a bigger portion of our patients are covered. They reflect the diversity of LA County even more towards minorities. Historically, before this year, 1 out of every 2 patients was new. How can you do continuity care if every other patient walking in the door is seeing you for the first time. That flux rate of 50% is one of the things we're going to have to tackle if we're going to be successful going forward. We see about 3 million ambulatory care visits. That's really one of the fun things about this department. Small little changes and improvement affect an enormous amount of people and have huge, huge impact for the entire community. We do nearly 440,000, put your arms around that number, 440,000 inpatient bed days a year, and close to 300,000 emergency department visits. We work in a really big, important place. So what's really the biggest change? There are two. One, patients are now empaneled. And empanelment is the association of a patient with a provider-led team who's responsible for all their primary care and the coordination of their care. The most important thing is we can finally answer a really important question. Who am I responsible for? 2-3 years ago, local medical directors up through the chief medical officer of the county couldn't really turn to a primary care doc, may I pick on you? Sure. And say, I'd like to talk with you about your patients. Because your patients were defined by who had the perseverance to wait the 4 to 6 months to get an appointment and remembered to show up when they didn't get a reminder call. That defined your patient population. That's not true anymore. Because we now, each of the primary care providers has a panel of patients that's known and understood and is in several different electronic systems to help them with their care. The newest program, which is only a few months old but growing like there's no tomorrow, is My Health LA. You might know it as Healthy Way LA Unmatched. And this is a program that's completely county funded. There's no state or federal money in it. Designed to help the remaining uninsured get primary care and focused on the community partner sites initially. It's going to eventually cover everybody, but right now it's community partner sites. Our patients are pretty sick. And why is that important? Because people with multiple chronic illnesses cost a lot of money to take care of. On the left-hand side of this graph is the Medicare spend for someone with no chronic illness. On the right-hand side, 5 or more. And it's even more dramatic if you take a look at it in terms of the percentage of the Medicare population that has concomitant diseases. So on the left-hand side, let's just take the top let's take the top 4 categories. That 20% of the population, they consume more than 90% of the health care costs. And there's one thing that's a guaranteed growth industry in the United States, and that's taking care of people with diabetes. The linear line is the rate of obesity. The curvilinear line below it is patients with diabetes. This graph's a little bit old, and the slope, guess what? Has it gone down? No, it's gone up. The slope, the rate of change has increased. So for those of you in this business, and for those of you who care about patients, remember, we want to be good doctors and prevent this from happening. We're now talking about being mediocre and bad physicians when we do as well as we can taking care of patients with diabetes. But we really have to figure out how to stem the tide of the obesity epidemic if we're going to really have impact. So why are we here? The first is to achieve the DHS triple aim. Mitch is brilliant in lots of dimensions, but one of them is distilling down our mission to 3 things. Taking care of more people who need care, doing it with the same or better quality at the same or lower cost. Everything that the department wants to do can be summed up in those 3 bullets. And if we're going to thrive, we have to do 2 things. Our patients have to like us. That has nothing to do with the clinical care you deliver. That has to do with how nice we are. And there, if you want to read some very good information, if you take a look at the turnaround of Sharp, Reese, Steele, and San Diego, they were in the bottom 3% of patient satisfaction a decade ago. They're in the top 1 or 2% now. By the way, does anyone know where we are in terms of patient satisfaction compared to others? Anyone want to guess? We're below where Sharp, Reese, Steele started. Okay? And what's interesting and important is, remember, 2/3 of our patients now have choice. So if we don't quickly learn that we have to be nice, we won't have patients to be nice to. The second part of what we need to do has to do with our clinical care, and that's the management of patients with chronic illness. So how are we doing with the 58, close to 60,000 patients with diabetes who were empaneled as of 2 months ago? I toyed last night with redoing these numbers because that number's already above 62,000 with the new patients who've been newly empaneled over the past 3 months. So it looks like we're doing really great on inpatient admissions and ED visits. 1 out of every 7 and about 1/3 of the patients in the past year having an encounter. That sounds terrific, right? Why shouldn't you feel so good about that number? Because that number only includes the visits that patients have in our hospitals. And where do patients go when they get really sick? They go to the closest ER around their house. So we have some unknown information that we're going to continue to put together. What we get is out of network claims, but that still probably underrepresents reality. These patients have a lot of outpatient visits. This is likely to be a real number, about 8 a year, but this is what's shocking. 1 out of every 5 get their care. These are empaneled patients with a named primary care provider. 1 out of every 5 get all of their care in urgent care or the emergency department. Anyone feel good about that? 20% don't have a hemoglobin A1C in the past year, and half of those had a scheduled primary care visit. And finally, about 20% also have a hemoglobin A1C above 9. So we can certainly do better. And how do we do it? I think it's always a combination of 3 things: people, process, and technology. Now, in lots of organizations, especially those that are driven by fee-for-service mal-incentives, this is really a problem, because sometimes doing the right thing hurts your income as a doctor. So one of the joys of having people on salary is we can really focus on doing the right thing. And, you know, it's one of the reasons I stick around here. We really have people who care about our patients, are mission-driven, and want to do the right thing. We, on the lofty 9th floor of 313, have been remiss in not providing you with the right tools until now. We already talked about empanelment. The second part of empanelment is creating a place where patients who have the association with the primary care team can do it effectively. And the patient-centered medical homes in DHS range from what would be an NCQA level 3 home, which is very advanced, very efficient, very collaborative, everyone working at the top of their license, to people who are like, oh, this is another fad, it'll go away. This isn't going away. This is how we're going to be taking care of patients going forward. And the thing that I'm really excited about is where we've gone in technology. And I like to think about this in 3 separate dimensions. One is analytics, looking through the retrospectoscope to understand what we've done and where we need to put our focus going forward. ORCID is here, and for those of you who think it didn't go well and smoothly, let me tell you, I spent the last 20 years of my career doing rescue of failed EHR implementations at institutions across the country. This is about as smooth as it gets. So switching over from one system to another and not having the place shut down is great. Yes, there are bugs. Yes, there are things that need to be fixed. But boy, hats off to everyone who worked on ORCID in the room. Just as a show of hands, how many of you had a piece of implementation of ORCID? Just raise your hands. Oh, come on, there were more than that. Okay, well, all of the credit goes to people who raised their hands. And for those of you who were too shy to, too bad. And then finally, and this is really important, ORCID is a system for taking care of patients individually, one-on-one, as you're taking care of them. It's not a population health system. Cerner has a population health system called Healthy Intent. It's not yet a product. They're building it now. We have implemented eye to eye. It works. It may or may not be what we use to go forward. And it's one of the big decisions that's yet to be made from a technology perspective in DHS. So let's take a look at what we know from some of our analytics. This chart, and by the way, you will get all the slides and all the handouts. This chart is what I name the AAA roadmap of chronic illness. And for those of you who are old enough to remember, the Auto Club used to have a mileage by city in 2 dimensions, and that's really how this is read. So if you take a look at the intersection of diabetes and diabetes, you'll see there are 74,000 patients with diabetes that we cared for in DHS. Now you may say, Jeff, don't you read your own slides? Didn't you just say it was 58,000 a few minutes ago? The 58,000 were the empaneled patients. The 74 includes people who just saw us in the emergency department or urgent care and don't get continuity care in DHS. Where a disease intersects with another disease, that means the patient has both of those. So of the 74,000 patients with diabetes, 45,000 or so also are hypertensive. But that's not the whole story. The whole story is really here. These are the number of patients who have multiple chronic conditions. And it's really interesting. Of the 74,000 with diabetes, only 16,000 have just diabetes. 22,000 have 2 other conditions. 25,000, it's going up, 3 other conditions. Remember that graph of cost? A lot of our patients are on the right side of that graph. This is the PCMH profile. This is, if you will, a balanced scorecard of how each team and each facility is doing. It has information on both your capacity and your workload, the breakdown of your patients, how your patients are visiting you, what chronic conditions they have. So this redacted provider has, 50% of their patients have hypertension, 45% have dyslipidemia, and 30% have diabetes. This is a sick panel. This is a really sick panel of patients. And right here in diabetes measures, this is a hemoglobin A1C under 7, 7 to 8, 8 to 9, 9 to 10, and above 10. Who would be interested in knowing, gosh, who are my patients who have hemoglobin A1Cs above 10 that I'm responsible for? And how could you get to that list? And the answer is we now have tools that let you do that. By the way, at the registration desk now, everyone who's in this room, your profile is sitting on the table and your facility profiles are sitting on the table. So during the break, go pick them up. And if you have any questions or you think the data is wrong, you can come and see me or Jeff Scheib, who's in the back of the room, who's in the middle of the room, and we can talk about it. But these have been pretty well audited, and people are shocked to find that they really have a few dozen patients on their panels with hemoglobin A1Cs above 10, and now we have a way of showing them. The final 2 things I want to show you from analytics are the breakdown of patients' hemoglobin A1Cs. So these are ordered by level of hemoglobin A1C and the percentage of patients, and by what drugs they're on. So first of all, of the 60,000 or so patients, just above half get their meds in our pharmacies. The others choose to fill their meds in Rite Aid or CVS, frankly, because you don't wait for as long as you wait internally in our department. And one of the things we really want to do, because it's better from a customer service perspective and it's better from a financial perspective for us, we really want those patients to fill their meds in our system, not outside of our system. So if you add up the 9 to 12 plus, it's about that 20 number, and about 20% are missing. So the first one is patients who are on any of these drugs. And you can see that, almost everyone's on metformin. About half the patients are on sulfonylurea. But the real eye-opener to me was only 10% of our patients are on a glitazone. And this is where I think I'm going to take my hat off to Dr. Davidson, because one of the things that the work group is going to talk about is one of our opportunities getting people who are out of control on glitazones. Now you might say, Jeff, what does it tell you if someone's on any one drug if you don't know the combination? Well, that's why we looked at the combinations. And if you take a look at people who are on metformin alone, you can see that for people who are out of control, above 10, there's close to 20% that the only agent they're on is metformin. Now again, we can now, for the first time with Eye to Eye, give you a list of those patients. You can find out exactly who those are. And we're going to go into this in more detail in one of the breakouts, so don't worry that we're not seeing all the detail now. But this kind of information, for the first time, is available to you and actionable. And this is an example of an Eye to Eye patient visit summary. The session with Jeff Scheibden this afternoon, I think it's track D, will go into detail in Eye to Eye. But all of the clinical alerts, the patient flow charts, their recent most labs, are all available in this nice one-page summary. And some of the really advanced patient-centered medical homes are doing this as part of the chart scrub and huddle, so that this becomes an attachment that allows the clinician to review the patient very quickly and easily, but most importantly, it allows the MA and the RN and the LVN to do the things that they can do under protocol before the patient ever comes in. So if a patient's a diabetic and you've made a med adjustment and it's been 4 months since that med adjustment and they don't have a hemoglobin A1C, think about how much more valuable your visit is if you know what the hemoglobin A1C is. And does it take a doctor's order individually to order that hemoglobin A1C?
In our system, yes.
Actually, in our system, no.
No, not our community partners, yes.
Okay, well, it doesn't have to, even in the community partners. So we have protocols that are going through the process of IDPC approval, and several of them have already been approved, which can be adopted anywhere in DHS, that allow the ordering of tests so that the visits are more productive. And I'm going to close with a quote from a good friend of mine, Ed Wagner. Many of you know him as the father of chronic care. He's the guy who came up with that nice diagram of unprepared patients, etc. And this really described what DHS was like years ago. Caring for chronic illness in most American practices features an uninformed passive patient interacting with an unprepared practice team, resulting in frustrating, inadequate encounters. And I think that's how most of us felt in primary care years ago. I'd like to close with, it can be different, it must be different. We, as a group, have a moral obligation to make it different, and that's why we're here. Thank you.
Great talk, Dr. Guterman. Really inspired us, and I think that's why we're here. Any questions from the audience?
Just in case we're lack of time, I have two questions, and if you can just pick one to respond, that would be great. First of all, I really appreciate the talk. It's so inspiring and amazing. And the first question is that following a good doctor's regimen, what do you see DHS responsibility for our pre-diabetic patients?
Oh,
the
that's
second
a tough
question, the second question is that what do you see the pros and cons of our PCMH to be certified by NCQA based on the current standard? We know they have a new standard this year, so.
Okay, two really, really excellent questions, and two both really tough questions. So I'll give you my personal opinion on them, but I'm going to suggest the first question is actually a very good topic for our work group to tackle and debate. The data on the efficacy of pre-diabetes treatments is not yet mature. So there clearly is very promising early information, but my personal opinion is it's not mature enough to make an operational decision on. For the PCMHs, across the ACN, we've now hired Qualis and Millman to do an analysis of our PCMHs, to do a roadmap of where they perceive we are. There was a conscious decision not to undergo NCQA certification, but we use NCQA requirements as part of how we measure ourselves. That may be revisited as we mature, and I think personally, so this now isn't the department's position, this is my personal position, I think people really like that little plaque on the wall that says I'm NCQA level 3, and there's some pride that goes along with that.
What was your name again?
Movie star Sean Penn.
Okay, great. I love your first question, and I think that's one of the issues that we're trying to address today. Is not only what medicines you give. Dr. Davidson said a good doctor tries to prevent diseases. So we're trying to look at our work group is some of the activities today are trying to look at preventive care. And we have the Wellness Center here today. This afternoon, we're going to talk about that. We're going to talk about, little things about diet and exercise. And I think this is the direction that I want our work group to go, is how do we facilitate in a huge system with millions of patients with different languages, different geography, how do we try to facilitate some of the lifestyle changes? How do we get parks available for people? How do we remove vending machines from schools? So I think, it's a huge issue. And it's not something that we're sort of used to doing, but I hope some of the other providers can help us do that, and we're going to have continuing dialogue about how to improve these bigger issues in the county system. Maybe one more question, one or two more questions, I think.
Actually, while you're looking and walking, I have a comment for our community partner colleagues. All the protocols that we develop in DHS are freely available to all of our community partners. Just ask. We're happy to share everything that we do. We're part of the same team.
Do you have any advice for overcoming that resistance on our administration that you're only doctors for labs and that kind of?
Yeah, but so the CCA-LAC has a venue to do that in, called the Clinical Advisory Group, or the CAG. That's where I would have that discussion. Yes, sir.
John Tycarby, UCLA, great presentation. Some of the patients wanted to kind of simplify their medicine count, their pills. I have many patients on 12 to 15 tablets. And I know it's not a great idea to go with combo therapy like at the pharmacies. It's kind of challenging and expensive. I'm wondering if we could kind of set up a group to focus on maybe adding a few cherry combinations that may improve adherence and also access our own pharmacies, because a lot of patients want to go out and try the new combo stuff, and none of that's available at DHS. Could you comment?
Right. So it's not only not available in DHS, a lot of the combos aren't available in commercial health plans either. The way our pharmacy works, we get incredibly good pricing through a program called 340B. So for example, a vial of insulin of regular or NPH, anyone want to guess what our cost is? Oh.
12.
Yeah, I realized I'm not allowed to say the number as I offered that. Here, it's a lot less, is all I can say. Does anyone know what the commercial cost of a vial of insulin is?
$100.
$100.
Yeah.
So we pay a lot less than the number that was said versus $100. So we have a skewed view of drug cost. None of the combo drugs are available on 340B. So the order of magnitude, typically 1 week of combo drugs equals a year of both drug supply.
Just to follow up then, can we add some of the single newer drugs in the pharmacopoeia for diabetes? There's like 4 or 5 new ones out there. Quite expensive, but maybe cherry pick a few that might be optional for our patients, because I think having that availability will keep our patients in our own pharmacy. Many of my patients go out because they can't get it, and they just go out and we do the tiered approach at outside like a Rite Aid or somewhere. And I hate to send the business there.
Right. As Dr. Friedman will tell you, we have long and hard debates over this, and there are 2 venues. So the work group that many of the speakers today are part of come up with recommendations that then get reviewed at P&T. And I will tell you, these decisions are not made flippantly. They're really made very, very thoughtfully. And some drugs like, the Invokana and the other ones that make you pee sugar, they seem very promising, and they're enormously expensive. But we also do chemotherapy that adds a few months of life. One of my roles is as the co-chair of P&T also, so I wear both sides of the hat where I argue in the endocrine committee how we need this, and then I go to P&T and I look at the budget. All I'll say is hundreds of hours of very smart people really do think of this in a thoughtful way.
I would add, though, that there are combos for blood pressure medicines that are probably underutilized. So that is a way, at least, to reduce some of you can do losartan plus hydrochlorothiazide as 1 pill instead of 2, and I don't think we use them as much as we could. So I think there are some ways to reduce your pill numbers.
Thank you very much.
Dr. Guterman, thanks so much. A great talk.